Good afternoon, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Subhash Kumar Wangnu sir. And let me share some of the achievement of sir. Sir has done MD in medicine, DM in endocrinology, FRCP from London, and senior consultant endocrinologist and diabetologist at Apollo Center of Obesity, Diabetes, and Endocrinology, Delhi. And today, sir is going to speak very important topic, that is male and female sexual dysfunction in diabetes. So, to know more about this topic, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here, sir.
Thank you for us. Very good afternoon to everyone, my friends and dear colleagues. I think today we are going to discuss a very important topic which is often not discussed so frequently in many of these scientific forums. That is the sexual dysfunction in male and the female diabetes mellitus. Why one should study the sexual dysfunction? Number one, everybody should know when you are writing the patient to be suffering from erectile dysfunction, that is ED, which is very common word. And the ED is basically defined as a persistent inability to achieve or maintain an erection suitable for successful sexual intercourse, leading to reduced quality of life. And the ED significantly affects emotional and well being and overall life satisfaction in men. The World Health Organization has declared the female sexuality to be not only part of health quality but also a basic human right. Now, why study the sexual dysfunction? The International Diabetes Federation, the IDF, estimate that globally there are 425 million people with diabetes. And diabetes is associated with many long term systemic complications, among which the sexual dysfunction is one of them in both the genders, male and female. According to a study which was published way back in 2020 in the Indian Journal of Community Medicine, 82% of the patients who were surveyed had some sort of the sexual problems. It's a huge problem. And the estimates of the prevalence of the erectile dysfunction in men with diabetes ranges globally from 20 to 85%. And in India, the sexual dysfunction among women is around 35%, and approximately 23% have a sexual problem associated with personal or interpersonal distress. Now, coming to the physiology of the erectile function. Normally everybody should know how the erection occurs. It is under the parasympathetic control, previously known as non-adrenergic, non-cholinergic neuron. And this neuron ending, they produce nitric oxide, and this nitric oxide is important chemical which is responsible for the smooth muscle relaxation in the corpus cavernosa. And this relaxation causes a sort of a negative pressure, and there is an increased blood flow in the corpus cavernosum vascular system, and this increased flow to the corpora cavernosa vascular system causes initiation of the erection. And also it also causes impact on the vascular endothelium, and which is causes the maintenance of the erection. This is in short how the erection takes place. And there are certain the enzymes and certain other chemicals like PDA5 which are important to take an important role in sustaining the erection. And that is why, because the PDF5 causes sudden degradation of the cyclic GMP, and cyclic GMP is important for maintaining the erection. So in men with erectile dysfunction, if you block the PDA5 by certain drugs, you can increase the concentration of the cyclic GMP, and that can help the patient to maintain and sustain an erection. This is in short the physiology and the science behind the drug, how they act in maintaining the erection. So the in short, when if we want to discuss in smooth muscle cells of the corpus cavernosum, the nitric oxide stimulate guanylate cyclase, which increases the cyclic GMP, which is the second messenger, which again activates the protein kinase G. It causes smooth muscle relaxation, and there is some hydrolysis, the hydrolyzed by PDF producing GMP smooth muscle contracts. So we had to look for the whether the in diabetes there's a improper or reduced secretion of nitric oxide, and also how we can block the action of the PDF to maintain the concentration of the cyclic GMP. Now coming to the other neurologically mediated arterial flow. There's a corpora sponges muscle, they get relaxed to allow the blood inflow and expansion of the cavernous vascular system. After that, there is a venous obstruction due to the compression of the outflow venules against the tunica albuginea, and that causes venous obstruction. And sometimes we see in some of the patient if there is a venous leak, the venous or incompetent, that this obstruction of the due to the compression of the outflow doesn't take place, and there is no maintenance of the erection. So there are certain newer mechanism to tell us about the physiology of the erection. There's some RAS homolog gene family member, which is called a row associated coil containing protein kinase pathway, which causes sensitization of the smooth muscle to the calcium, and there induces the formation of the stress fibers and the focal adhesion. Then there is myosin, phosphorylating myosin light chain actin binding of the myosin, which causes the contractility. Inhibition of this pathway causes relaxation of the cavernous muscle, and which causes the sustained erection. Why I'm talking all these mechanisms? Because it will help you to understand the mechanism of the various treatment modalities for treating the male and female sexual dysfunction. So this is a normal, the no nitric oxide mediated smooth muscle relaxation and the ROCK pathway inhibition, and the erectile dysfunction. The underlying factors are the hyperglycemia, hypertension, dyslipidemia, obesity, smoking, and all of them are associated with endothelial dysfunction and autonomic neuropathy, and the failure of nitric oxide production from the nerve terminal induce smooth muscle relaxation. So this is in short. Coming to the female sexual response, that is dependent upon the CNS and limbic hippocampal structure activation. Parasympathetic and sympathetic fiber transmission leads to the sexual arousal, genital vasocongestion. It increases the clitoral intracavernous stimulus, like in penis. The counterpart in the female is the clitoris, and that gets engorged. And there's an eversion of the labia minora, vaginal wall relaxation, so that it helps in penile penetration. So any of the pathway which gets disturbed, it may lead to the female sexual dysfunction. Now, the classifying the female sexual dysfunction, the reset is the ICD-11. Initially, the ICD-10 has been abandoned. So we have seen that either we call it hypoactive sexual desire function, the sexual aversion has been discontinued, and the female sexual arousal dysfunction has been replaced from the lack of sexual enjoyment and failure of sexual response. Orgasm dysfunction has been retained, and non-organic vaginismus has been replaced by the sexual pain penetration order. The causes of the female sexual dysfunctions are many: psychological, organic, and the psychosocial. The psychological factor in the female sexual dysfunction is because of the either the overweight, and they cause what you call the alter the self-image, Increased risk of depressive symptom, loneliness, isolation. It also causes decreased quality of life. And sometimes with the females on antidepressant, the side effects from the antidepressant and antipsychotic moods may have underlying factors for the psychological factors. So when you are taking a detailed history, be sure that female is not taking any antidepressant. Other organic factor in a female sexual dysfunction is same as in the male. Uncontrolled blood sugar, neurovascular alteration as in the male, hormonal changes and recurrent genital infection because of the uncontrolled diabetes. Vulvovaginitis, the candidal vulvovaginitis, it may cause dyspareunia, and that is why it may lead to the some of the organic factors. So hyperglycemia, let's talk of the hyperglycemia. How does the uncontrolled diabetes lead to the organic factors? Decreased mucous membrane hydration, there is a decreased lubrication, which causes painful intercourse. Increased risk of because of uncontrolled diabetes, UTI, and vaginal candidiasis, which I already discussed. Increased advanced glycation end products, decreased production of nitric oxide as in male, increased reactive oxygen species, which all causes endothelial dysfunction, and decreased libido because of the uncontrolled diabetes. So we discussed hyperglycemia, psychosocial factor. Let's come to the organic factor. The vascular damage to the endothelial dysfunction, causes decreased vaginal blood flow and it causes impaired arousal response. Insulin and insulin-like growth factors can regulate the activities of the important enzymes of steroidogenesis, such as aromatase and 3-beta hydroxysteroid dehydrogenase. Diabetes is associated with the polycystic ovarian syndrome or thyroid disease, which is again an important organic factor for the female sexual dysfunction. Important list of the drugs which every treating physicians and healthcare provider should know. Antihypertensive, which are known to cause sexual dysfunction, like thiazide, beta blockers, the commonest culprit, calcium channel blockers, ACE inhibitors, aldosterone receptor antagonists, ARB, the aldosterone receptor antagonist, antidepressant like tricyclic antidepressant, monoamine oxidase, MAO inhibitors, phenothiazines, haloperidols. The estrogens and anti-androgens also responsible for the females are on for causing the sexual dysfunction. Cimetidine is important, Regoxin is important, metoclopramide, which is a very common prescribed drug, and 5-alpha reductase inhibitors are also an important drug for causing the female sexual dysfunction. Alcohol, tobacco, marijuana, anabolic steroid, barbiturates, opiates, amphetamines. You know, it has been said, the Shakespeare said, alcohol increases the sexual desire but takes away the performance. So there has to be limitation of the alcohol intake in order to prevent the sexual dysfunction. Now, the conditions which might be associated with the erectile dysfunction about the performance anxiety. The male is doing for the first time, whether he'll be able to successful. That is called the performance anxiety. Psychological trauma in female, that they are afraid of the bleeding, if there's some difficulty in penetration. Sexual problems in the partner is another important part for the sexual dysfunction. Peripheral vascular disease, again, and I told you all the associated conditions like diabetes, thyroid disorder, hyperprolactinemia again is a very important factor for the male sexual dysfunction, thyroid dysfunction, dyslipidemia, renal disease. In certain neurological disorder like multiple sclerosis, spinal and pelvic trauma, hypertension, smoking, drugs, alcohol, which I already told you, structural abnormalities of the penis, if there is a bend in the penis, or there is some what I call the rigidity, sometimes what I call the patients get painful intercourse after the erection. and there may be some fibrosis which causes the painful intercourse. Now, coming to the basic concept when a patient or the both the male and female partner comes together, how to evaluate the patient. There's some questionnaire what we give to the patients, and we calculate the female sexual function index. FSFI 19 is being used. You can download the questionnaire from the web or the Google, which is the most commonly used psychometric diagnostic test to identify female sexual dysfunction. FSFI is the 19, but FSFI 6 is validated for screening only for sexual dysfunction in women. And for the males, we use the International Index of Erectile Function 5, and a sum score of 21 or less indicate the presence of erectile dysfunction. And this is nothing index. We give a questionnaire to all the patient. After, you can download the International Index of Erectile Dysfunction, give it to the patient. He fills out the form in the OPD while he's waiting for the doctor, and you can diagnose whether the patient is having erectile dysfunction or not. Let's start with the female sexual dysfunction. First of all, elicit the patient history, name, and reframe the attention to the sexual concern or problem, empathetic witnessing, and referral or assessment and the team. Maybe we might have to refer to a psychologist to just sure whether there is any other associated problem or not. Now, there is a stepwise model. Started was screening, and the second is to take the patient history, then is the care level assessment, and then there is a care level treatment. I'm going to basically in detail discussing all the stepwise treatment in female sexual dysfunction. This is another scoring called the domain scoring, where the domain, the number of the symptoms you ask from the patient: desire, arousal, lubrication, orgasm, satisfaction, and the pain. And all of them are given a number. The minimum score is 2 and the maximum score is 20. So this is another of the what a female sexual function index. And this is the International Index of the Erectile Dysfunction, which you can download from the link. I have written you one of the what are the questionnaire you can ask from the patient, and you can again give the scoring for evaluating the erectile dysfunction. When you are eliciting the history, just see whether the onset is gradual, whether it is progressive, whether in the early phase there is a sustained erection affected, or the erectile failure is not sustained, intermittent, maybe dependent upon the moods, the environment, other thing, or it is a sudden onset erectile dysfunction which can be psychogenic if you have a fight within the family or something, and the loss of libido. And the loss of libido has many of the important elements because of the various diseases and the comorbid condition. You have to examine the external genitalia in the male, whether the patient is ecchymosis because it may cause painful intercourse. If the testicular volume is normal, if it is very low, soft or tender, then you can tell the patient that you are having hypogonadism. And then you can evaluate whether it is hypogonadotropic hypogonadism or the hypergonadotropic hypogonadism. For that, you require serum LH, serum FSH, lectin, testosterone. Has to be done in the fasting early morning, and we have to take 2 samples, and we do the assay in the pool sera. Associated conditions, you do the cardiovascular status examination by doing ECG, echo, serum lipid profile. For glycemia, do HbA1c, electrolyte to see for the again the electrolyte imbalance. And most important part is the penile Doppler study. In our hospital, in the Apollo Hospital, we are doing penile Doppler study routinely because many of the patients, what we have diagnosed is the because of the endothelial dysfunction, the erectile dysfunction, or the psychogenic, or because of the Venous leaks, because we have the facility for doing surgery for the venous leak, and they do better after the surgery of the venous leak. If there's an endothelial, severe endothelial dysfunction, then it becomes a problematic for diabetes, long-standing diabetes, to treat the erectile dysfunction. Now, coming to the last few slides of the erectile dysfunction: lifestyle modification, physical activity, weight loss, avoiding smoking and alcohol consumption, glycemic control, and some other pharmacological options. Lifestyle modification again depends on whatever kind of exercise you're doing, diet control, regular physical activity, which helps a lot in improving the oxidative stress and improving the endothelial dysfunction. Weight management, all are important because the weight loss causes a dramatic improvement in the cytokines, oxidative stress, and also improve the total and free testosterone in patients who cause this significant weight loss. Patients should be advised to have a very healthy eating plate, avoiding the fats, the particularly even trans fat and saturated fat, increase consumption of the fiber, cut down your carbon intake to less than 60%, and do regular exercise. Smoking is again important factor. Avoid smoking because direct use of tobacco and even the second-hand exposure seems to be consolidated risk factor for the erectile dysfunction. Moderate consumption of alcohol may exert a protective effect. Moderate means less than 21 drinks per week. Don't take more than that because otherwise you are going to have problem with the intake of the alcohol. Cornerstone of the control of erectile dysfunction is the glycemic control. And the poor glycemic control, I told you the mechanism I have explained, it increases the risk of erectile dysfunction 2 to 5 times. Now let's talk about the most of the commonly used drug. Most of the physicians are using the PDF phosphodiesterase 5 inhibitor. The drugs which are available, the sildenafil, vardenafil, and tadalafil. Two common drugs what we are using, the sildenafil and the tadalafil, and but we have to see whether the patient is not having side effect or the patient is on nitroglycerin or nitrocontin you have to avoid, otherwise causes severe headache. There is another intracavernosal injection therapy which we have to teach the patient to inject the L-prostadil. It is available, but sometimes it causes penile pain, prolonged erection, which is priapism, and the fibrosis. Sometimes we combine L-prostadil plus papaverine, but what we are comfortable is using the papaverine injection alone. We give them the pre-filled syringe of the papaverine and give a demonstration in the hospital how to inject in the corpora cavernosa, and the patient gets trained to inject it at home before having sexual intercourse. There was another transurethral L-prostadil for the urethral system, which is not available in our country. Initially, when I was using about a decade back, then it was freely available. But that is again is very costly affair, and it does not cause so much of good effect as compared to the intracorporal cavernosal injection. There has been some topical prostadil cream which is aligned, applied around the urethral meatus, which contain this particular compound, and it is also not available right now in our country. Vacuum therapy has been used for time immemorial, and I have personally experienced using the vacuum therapy. There is a translucent tube, air is pumped into the tube, a construction band is applied at the base of the penis, and when the vacuum causes erection, the flow is blocked by the band. Band is provided along with the vacuum pump, but sometimes it causes pain from the construction ring, and sometimes in some patient does not causes much effect unless a patient is comfortable using this device. Penile processes, our hospital is well equipped for the penile processes. We have done many of the penile prosthetic surgery in long-standing diabetes where none of the modalities occur. But only problem is that the post-injection corporal fibrosis has to be taken into care. And there is some venous surgery which I told you for the leaking venules, the venous leak. For female sexual dysfunction, there is no specific guidelines available. Some people use HRT, and some of the drugs which has been used in female dysfunctions, which I have mentioned here. So these are the drugs which are not available, what I have mentioned here, and it is available online. And if you MG1, MG or Google, you can get these drugs. And one of the important drugs, fluoxetine, is very important drug which can be used. Sometimes people use vaginal lubricants, moisturizer, pelvic floor therapy, but these two drugs are important, which can be obtained through the Google. And ladies and gentlemen, my dear friends, sexuality has a fundamental role in healthy equality, is a fundamental right for the female and the male. It is an important but often neglected complication, but nobody discuss with the patient. Early diagnosis and prompt treatment of ED can be very rewarding to both patient and physician. Required multidisciplinary approach, including a diabetologist, a specialist in the sexual health, and psychotherapist. Thank you very much, and I'm ready to take any questions from the audience. इसको कैसे हटाएं?
Thank you so much, sir, for your valuable time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, I can see, sir, we have received some question. With all your permission, shall we take these questions?
Oh, sure.
The first question I can see is from Dr. Amarjeet, and he's asking how does chronic hyperglycemia contribute to endothelial dysfunction and subsequently erectile dysfunction, sir? What's your
See,
point of view?
chronic hyperglycemia causes a sort of a pro-inflammatory reaction, and it causes the release of various cytokines and what you call adipocytokines. The important one are the interleukin 6, adiponectin, and the reactive oxidation species, which directly increases the oxidative stress. And oxidative stress as is an important part of directly attacking the endothelium and causes the endothelial dysfunction. If you see, the endothelial dysfunction is a kind of a pro-inflammatory reaction because of the direct hyperglycemia. And this endothelial dysfunction causes erectile dysfunction in the way I told you that the nerve endings they produce nitric oxide, and the nitric oxide further increases the cyclic GMP. But unfortunately, the cyclic GMP is degraded, but because of the PDE5 and the generation of cyclic GMP is affected because of the endothelial dysfunction. So this is the reason for the hyperglycemia causing erectile dysfunction.
Thank you so much, sir, for sharing your point on this question, sir. Moving forward, I can see another question from Dr. Subramanian. He is asking how should clinician address the risk and benefit of testosterone replacement therapy in diabetic men with low testosterone levels?
I think it is a very good question. The androgen replacement hypogonadism is when the testosterone is low and the patient is also having sexual dysfunction. There is a clear-cut laid down guidance by the Endocrine Society, the United States Endocrine Society clear-cut laid down guidelines. So what they say, if the testosterone is persistently below 250, if the testosterone is persistently below 250, they can start with the testosterone replacement therapy, and the indications you have to ask the patient whether it is really affecting his life or the psychological status. And the replacement therapy is in the form of injections, in the form of local gel, in the form of the local patches. And the injection has to begin starting with a small dose every 2 weeks, from 100 milligrams, stepping up to 250 milligrams. And it has to be continued till the patients, and you have to continue it because when the testosterone is low, it can't be bring back to the normal. Some people prefer to take gels, some people prefer to take patches, but I am very happy with injections. But Only thing you have to monitor every 3 to 6 months urine routine microscopy, hematocrit, PSA, prostatic size, and liver function tests. And all of them normal, you can safely continue testosterone injections.
Thank you so much, sir, for sharing your point of view on that question also, sir. As I can see, sir, there is no more question. Amarjit has written, thanks for your response, sir. I hope, sir, he has got the answer and he is very much happy with this session. As, sir, there is
Thank
no
you
more
very
question.
much.
Welcome, sir.
Thank you very much for us. It was a very nice talking to you, and let's hope the
Yes, sir.
people might have benefited by this talk, which is undoubtedly not commonly discussed in many of the CMAs. Thank you very much.
Yes, sir. We would like to see you in future also with different topics, sir. Till then, take care of yourself, sir. Have a great day, sir.
Thank you
Thank
very
you so
much.
much.